All right, I want to remind you where to find us, healthwealthandwisdom.org, but always 1250 wins, 7 to 9 p.m. Monday through Friday. Also, if you're not at your computer, where you can go to WHNZ.com or not by your radio, you can download us on your smartphone. It's very simple. Just download iHeartRadio, and you can listen to all the great Clear Channel stations, especially 1250 wins right there. We're talking right now to Dr. Ash Tewari, and he's with Mount Sinai Hospital, Icahn School of Medicine. Prostate cancer is a topic. So, Dr. Tewari, what are the risk factors for prostate cancer?
I think age is the commonest risk factor. As we grow old, we increase our chance of getting prostate cancer. If we have a family member who has prostate cancer, especially father or uncle or brother, it increases our risk of prostate cancer. If we eat too much of animal fat, or if we eat too much of red meat, that increases our risk of prostate cancer. Multiple infections, we are not sure, but I guess can also increase the risk for prostate cancer.
Now, when you say multiple infections, do you mean like urinary tract infections or just in general?
That's right, prostate infections and all those things. Multiple.
Okay.
I mean, it's not proven, but people are suspecting that chronic inflammation infection can be a risk factor.
So now when you look at those risk factors, there's not that much you can do to prevent prostate cancer, right?
Actually, eating right is a good thing. And
okay.
I didn't mention one more thing. I mean, high body weight sometimes can be a risk factor. So keeping our weight in the right range is also an important thing.
All right. And so when people are thinking about, I should get screened for prostate cancer, is there a specific age like there are for many others? Is 50 that mile marker?
Yeah, it's about a little above 50. People should start engaging in a discussion about prostate cancer. If a patient has had an PSA before and that was abnormal, they should be talking about it. Patients who have a family history, patients who are from the African American race, they are at a high risk and they should be getting it done a little sooner. But for most people beyond 55, they can talk about it, and we usually stop this process at about 70.
Okay. And so what exactly is the screening that goes on?
So it involves a good medical history, getting a detail about the family histories or the medical issues, any urinary problems, any blood in the urine, any prostate symptoms. And then we do an exam. We also collect the blood for the PSA exam. And combination of these things is what we call early detection for prostate cancer.
And are all these screening methods pretty darn effective? I mean, they're going to get you the information you need?
I mean, I think if used in combination and done by an expert, it's reasonably a good test. Sometimes the problem is that it may be a little oversensitive. So not every abnormal PSA needs something to be done. And that is where we need to be sure that we are talking to someone who can interpret the PSA. One single value of PSA being abnormal may not mean that much as a profile may mean, meaning if the PSA is rapidly going up or if a younger person PSA is a little high. So these are accurate, but they need an interpretation by an expert.
Okay. Now, you said that you start around 55, you end around 70. Now, why end around 70, a lot of these tests?
I mean, these rules are not the real rules. If I will screen anyone or I'll look at any patient for risk of prostate cancer if he walks in my office with his father, even if he's 70. What I mean, it's about the life expectancy. And,
right.
Then 75-year-old who is running a marathon has a different life expectancy. But for an average, these are the guidance.
Now, is there any truth? I heard this a long time ago, and I sort of hung my hat on this with my wife. Is there any truth that getting a vasectomy could increase your chances for prostate cancer?
Yeah, actually, 10, 12 years ago, there was a lot of discussion about that. It didn't kind of got full validation, but it was a suspect for the longest time. But today, I think we cannot say that it is a risk factor.
Okay. Okay. So now, like you spoke about earlier, someone is diagnosed with prostate cancer, and most people think, okay, I got to get this treated. But again, it's one of those things where you're looking at what exactly the test results are and then seeing maybe this is something we just watch for a certain period of time.
That's exactly correct. The most important thing patients need to know is their Gleason score. So every cancer which gets a diagnosis of cancer actually should have a Gleason grade assigned to that. And that grading system was developed by Dr. Gleason. And according to that, if someone's Gleason is 6 or lower, he's a good candidate for active surveillance. If they have a Gleason 7, then that means the cancer is a meaningful cancer. If they have a Gleason 8, 9, or 10, that essentially means it's a little bit more aggressive cancer.
Okay. And the treatment options, I mean, there's been huge advances in treatments, hasn't there been in the last decade?
Absolutely. There are treatments, we group them into 3 broad categories. So one is in whole organ treatment, meaning radiation or surgery of some kind. Then we have treatments which are just the partial organ treatment, like focal therapy. Or sometimes we have systemic therapy in which we use hormones or radiation, even vaccines which have come up now. So there are many options now available. And in the treatment, of course, if you talk about surgery, there are open and the robotic, different kinds of surgeries available.
And when you're doing surgery, is that typically you're removing the prostate at that point?
Yeah, I mean, I think surgically we want to take the cancerous prostate out with the least disruption in the surrounding structure.
Okay, and so at that point, I mean, do then patients have a lot of those other problems like incontinence and things like that, or it really comes down to the surgeon that's doing the work?
I mean, part of it is surgical experience, part of it is what kind of a cancer they have. I mean, a good number of patients get the function back, but there is a small percentage of patients, either because cancer is a little too close to the nerves or too close to the sphincter, they may have an issue because that may need a fixing. But most of the patients, if they have an early cancer, they do well.
And then is it considered that if someone's had their prostate removed, you're cured?
Yeah, I mean, I think I would say more than 90% of the early cancers, they get cured.
Okay. But is there anything to watch in the future? If someone was at that 8, 9, and 10 level, they had to go in and get, like, let's say, the robotic surgery to get their prostate removed. Is there anything that they have to watch after that?
So this is a very good question because Gleason 8, 9, and 10 and the cancers which are escaping the prostate, they still can be cured by surgery, but we have to follow them very, very closely. And some of them need what we call an adjuvant or a salvage treatment. We follow them with the PSA level every 3 months in the beginning. And if PSA shows a climb, then we give them either hormones or radiation, and that's known as salvage therapy. Sometimes we look at the pathology, we look at the grade, we look at the lymph nodes, and we feel that even though the PSA is normal after surgery, we still go ahead and recommend that you should have a radiation or you should have hormones, and that's known as adjuvant therapy. So we keep a very close eye on these patients by sequential PSAs and sometimes imaging of different kinds. Gotcha.
Very interesting. All right. Well, Dr. Tewari, I want to thank you for joining us. MountSinai.org. You can find all the information there. And they can find more information on prostate cancer and robotic surgery there, right?
Absolutely, they can.
Great. Thanks so much for joining us, Dr. Tewari.
You're very welcome.
All right. Our pleasure. It's a scary thing, right? I mean, I guess for women, it's breast. For men, it's prostate, know. And you know that old joke, right?
What?
Why does everybody pay attention to breast cancer versus prostate cancer?
Tell me.
Because you never saw 2 women sitting on a porch and going, look at the prostate on that guy.
Oh, yeah, right.
So, All right, but you know what? It really is. I got to tell you, I've had friends that have gone through this. Any of our listeners out there, I implore you to go get an expert's opinion if you've been told this. I unfortunately have a friend that's really had a tough time with it. I mean, he doesn't leave his house. He's got a lot of problems, and this happened. I mean, I didn't even know he was going through it till way after the fact. So I would tell you, we've got, Mount Sinai is a great place, but we've got Moffitt Cancer Center here in Tampa Bay. There's other great specialists. And I would really get to someone that can really give you a lot of these answers and really has great expertise on this topic. So make sure you do that, because it's serious. I mean, it really can curtail someone's complete lifestyle, and it doesn't have to anymore, not with the treatments that these guys have. All right.